Let's go ahead with the case presentation, given the fact that I've got the privilege of having both medical oncology and urology here. So our patient this morning is a 62-year-old Caucasian male who was referred to his local urologist for a PSA of 6 nanograms per ml. Has no voiding symptoms, but does have a strong family history of prostate cancer. He was evaluated, and it was determined that he should undergo a 12-core biopsy, which showed 4 out of 12 cores, 40 to 60% of each core positive with Gleason score 4+3. After a long discussion with his urologist and going over the various treatment options, the patient elected to undergo robotically assisted radical retropubic prostatectomy. His final pathology, however, showed a Gleason 4+3 pathologic T3A lesion with a questionable apical surgical margin, node negative, no evidence of metastatic disease. He did fine postoperatively, was followed by his urologist, and his PSA natered at 3 months to 0.2 nanograms per ml post-prostatectomy. So, Larry, Lenny, you all see these patients pretty routinely. Can you comment a little bit about his nadir of 0.2, pathologic margins, T3A lesions? How does that affect your thinking in terms of, at this point, managing of this patient moving forward?
Well, this gentleman obviously raises some concerns, which is why you're using him as an illustrative case. He's got fairly high volume disease. He does have primary Gleason pattern 4 cancer. And then there's also the issue of the questionable positive margin. The good news is he has negative lymph nodes, and that certainly is encouraging. However, the challenge that we have right now is, when do you initiate post-operative radiation therapy in this particular setting? The margin at the apex is questionable. It's not really clear. It's a positive margin. Some of the studies suggest that an apical positive margin may or may not have the same impact as, let's say, a base or a lateral margin. So that's a little bit questionable. What is concerning, though, as you alluded to, is that he did not come to an undetectable PSA level. He sort of is parked at 0.2, at least on this 3-month follow-up. That is concerning, that there might be some residual disease. So what we would do at our center is we would run him through a nomogram, one of the different ones that are available, and sort of determine his risk of recurrence. Certainly in the future, we're going to have genomic assays, which I think will revolutionize the management in this particular patient. But we look at a nomogram, and if he had greater than a 50% chance of having progression in the future, based on a nomogram, we would probably recommend post-op radiation after usually 6 months, when his continence is fully restored.
Larry, is that sort of how he'd managed to tuck?
I would agree with Lenny. You know, I think the troubling thing is that he never became non-detectable as far as his PSA, and so you know that this patient probably has some residual disease. And the question is, do you wait till they get to PSA of 0.4 or 1 or 2? I think this patient probably does have residual disease, and I think I would consider radiating sooner than later for this patient.
Okay.
And I think, Raoul, if you look at the AUA guidelines in this area, that they're going to really suggest that this person should have a serious discussion based on these characteristics about having post-operative adjuvant radiation therapy.
Is the more concerning point that the fact that he didn't go all the way to less than 0.01 or less than 0.008 and just stayed at 0.2?
Yeah, I think that is certainly very concerning. Now, he doesn't have a rising PSA, but obviously the time course is really too short for us to determine that.